Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from the USA, Prof. Adil Malik. Dr. Malik is the Chief of Neurovascular Surgery and Director of Cerebrovascular and Endovascular Division in the Department of Neurosurgery at the Tufts Medical Center and Professor of Neurosurgery at the Tufts University School of Medicine. He is a board-certified neurosurgeon in Boston, specializing in the treatment of brain aneurysms, AVMs, and stroke. He is dual-trained in both microsurgical and minimally invasive endovascular neurosurgery. His research includes study of hemodynamics and mechanotransduction of brain aneurysm development and advanced 3D imaging to improve safety of neuroendovascular therapies. Dr. Malik is a co-inventor of the E-Shunt endovascular device for the treatment of communicating hydrocephalus. We are extremely honored to have him today at the webinars, and today we'll be talking about first in-human use of transdural shunt for hydrocephalus. The speaker for the second session of today is one of the most prominent neurosurgeons from the UAE, Prof. Wasim Aziz. Dr. Aziz is a consultant neurosurgeon and chair of neurosurgery at the Sheikh Shakbut Medical City in Abu Dhabi. He is a vastly experienced neurosurgeon with over 23 years dealing with complex cerebral and spinal pathologies. Dr. Aziz is a distinguished professional in both academic and clinical settings. He previously served as a consultant and head of Department of Neurosurgery at the Med Clinic and a consultant neurosurgeon at the Tawam Hospital. He received his fellowship in skull-base surgery, endovascular neurosurgery, and neuroanatomical studies at the Kyoto University of Japan. He completed his research at the Barrow Neurological Institute in USA and also with the Foundation Rothschild in France. He was granted the prestigious Associate Professor title in 2018 in the Department of Neurosurgery at the University of Alexandria. We are extremely honored to have him today at our webinars, and today we'll be talking about multimodality treatment of AVMs, the hybrid perspective. The chair for the first session of today is our honorable guest from the USA, Prof. Walid Brinchki. Prof. Walid holds the rank of Professor of Neurosurgery and Professor of Radiology and Consultant in the Division of Neuroradiology, Department of Radiology at the Mayo Clinic, Rochester, Minnesota, USA. His clinical interests are focused upon the management of cerebrovascular diseases, mainly cerebral aneurysms, AVMs, and stroke. He is a noted scholar who has authored and co-authored more than 400 articles in various peer journals, and he has also been a pioneer in the development of newer interventional procedures like endovascular management of intracranial hypotension. We are extremely honored and grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable faculty from Rome, Prof. Simone Pestillo. Prof. Pestillo is a specialist in neurosurgery, adjunct professor at the St. Camillus University of Health Sciences, where he is the Guido Guglielmi Endo Chair for Endovascular Neurosurgery. He is a member of the vascular section of the ACNS as well. He is the director of fellowship program in the vascular and endovascular neurosurgery in the St. Camillus University. He is also a visiting professor at the Department of Neurosurgery in the Hyogo College of Medicine, Japan. He has performed more than 1,000 endovascular neurosurgical procedures in Italy and abroad, and has authored and co-authored over 100 articles in various international journals. We are extremely honored to have him today and grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President of Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Prof. Walid Brinchki.
Hello, thank you very much for the kind introduction. It's an honor to be chairing this session with Professor Adil Malik. As many of you may know, Dr. Malik is the inventor of the E-Shunt, which is truly a novel approach for the treatment of communicating hydrocephalus, normal pressure hydrocephalus. He has done an incredible job building a company over the course of the past several years, and has done incredible translational work in both animals and then translating it to humans, with many patients having been treated to date. As an interventional neuroradiologist, I would say that this is probably the most transformational thing that I've seen in my short career. But this is probably the most exciting thing, and I really do hope that it does come to fruition, because it's really kind of expanding the opportunities for our field in general, and also bringing a very novel and minimally invasive approach to treatment of communicating hydrocephalus. So with that, I'd like to introduce Dr. Malik to give his presentation.
Okay. Thank you very much, Professor Brinchki, and thank you very much, Professor Krishnan Kudi, and everyone at the ACNS for this opportunity. I'm going to talk to you today a little bit about the eShunt device, which is really something that came up after thinking about how microsurgical clipping has really been over time in the recent decades really been supplanted by or complemented by endovascular techniques, initially simply with coiling, increasingly with more complex devices. This work has really been a partnership with my colleague, Carl Hellman, who specializes in skull-based surgery and who's actually been a proponent of endovascular technique. And so it's come as a fruition of many sessions of discussions and brainstorming. One of the problems that is obviously central to neurosurgery and neurosurgical management is hydrocephalus. And yet the technique for treatment of hydrocephalus remains somewhat unchanged for the last number of years. And although many of us have excellent practices with very low rate of complications, nonetheless, if you look at the overall rate of complication from VP shunt, it tends to be blighted occasionally by significant complications, despite our best attempts. They include distal catheter malposition, slit ventricles in cases of idiopathic intracranial hypertension, catheter misplacement, although that has been decreasing with the use of stereotaxy, overdrainage and subdural hygromas or fluid collection when the patient stands up without and this, of course, has been decreased by the use of anti-siphon devices and intracranial hemorrhage. This study suggests that there really hasn't been a dramatic improvement in methods for treatment of hydrocephalus, although, of course, there are catheter antibiotic impregnated catheters, adjustable valves, anti-siphon and gravitational positioning valves that have continued to improve the current existing VP shunt. So our thought was, would it be possible to develop a method whereby we would use a biologically inspired approach, try to take an arachnoid granulation, which is felt to be the major mechanism for CSF reabsorption from the subarachnoid space into the venous system, and design a device that would effectively mimic that, and that could be deployed from an endovascular approach. Our initial thought was to use some kind of a mechanism that would enable us to stabilize a catheter for delivery, and then effectively make a access through the dura and then connect the space containing the CSF to the venous system. As you know, the ICP is always higher than the venous pressure by a few millimeters of mercury. And upon examination of the different areas that we could reach in a safe fashion in a transvenous approach, we initially thought of the sigmoid sinus, where in many older patients we can find a space that we could potentially take advantage of, possibly transverse sinus or superior sagittal sinus. But all of these are very important critical pathways for venous drainage, and any injury or thrombosis during the intervention could be very critical. And so the space in the cerebellopontine angle cistern became of interest to us because it's an area that is quite constant despite changes in CSF pressure. And we know that it's an area that is routinely accessed for intervention, increasingly now with venous interventions of the large sinuses with venous stenting, but increasingly the increased facility of access of the venous system is supplemented by the fact that most of the neurointerventional community is well versed with accessing the inferior petrosal sinus that you see here, and both for petrosal sinus sampling, but also for treatment of carotid cavernous fistula. And the inferior petrosal sinus here is separated from the cerebellopontine angle cistern by this dural membrane. And the other advantage of the inferior petrosal sinus is, unlike other veins or arteries intracranially, it is actually in a bony channel, so that the maneuvering of a catheter would be very well controlled and would not be hampered by motion of the underlying vessel or vein during the deployment. This is just showing that this is a routine path. This is just a dual compartment carotid cavernous fistula. One of the features of the inferior petrosal sinus that make it attractive is the fact that it has this natural tendency to change angle. Whenever you have an angle change, it provides an opportunity for an off-axis, transdural or trans-IPS access. It can be visualized nicely with MRI with gadolinium enhancement here. This would be multiplanar reconstruction. And so the idea, again, is to breach this in a controlled fashion from the venous compartment into the cistern, and then deliver a device that would then enable us to, in a controlled fashion, drain CSF and mimic the arachnogranulation. The initial design requirements from such a shunt would be that it would effectively require a certain threshold before it starts to flow. And if there is a reverse gradient, let's say when you are coughing, sometimes the venous pressure may transiently be more elevated than the ICP. The provision of a slit valve, which would be able to resist reverse blood flow up into the shunt and then potentially having the blood enter into the cistern. So this valve would prevent that. And the target for flow is around 10 milliliters per minute. Per hour, which is effectively what we drain patients with subarachnoid hemorrhage, usually in the intensive care unit. So we did an analysis of a large number of patients to look at the anatomy, the IPS, diameter, and also other features that would enable us to advance into this cistern in a controlled fashion, and design this e-shunt device that has what's called a Malacot, which is a nitinol self-expanding anchor that would prevent the pull-through of the device into the venous system. And this would enable a controlled delivery until final release. So the actual lumen of the device is quite small. And so one would think, how is that going to remain patent compared to the tubing of the VP shunt that we see? One of the concern is how is this possibly going to work? But the truth is, if you think of the length of the VP shunt tubing, it's much, much longer. So the resistance may be close to equivalent, and we'll show you some videos. The other thing to consider is because of its short length and the small diameter, it will actually enable to have rapid CSF velocity inside the tubing, and this will prevent the possibility of sedimentation of protein and stagnation of the CSF like you would see in a valve or the chamber of a typical VP shunt system. This is the flow through the slit valve that you see in this in vitro model. And this is a sheep experiment where we actually analyzed the concept of transvenous, transtrocular access into the cistern to evaluate the risk of subarachnoid hemorrhage from such a procedure. We hypothesized that because the CSF pressure is actually higher than the venous pressure, that perhaps going through the wall of the vein may not be as dangerous or as risky as what we all fear when we're performing endovascular aneurysm treatment, the perforation of an aneurysm when you have potentially catastrophic increased ICP from rupture of the vessel. So in this set of sheep experiments, we actually went through the needle across both the external and internal wall of the sinus into the cistern, and then performed CT scan. And we actually did not encounter any new subarachnoid blood or any subarachnoid blood from this intervention. This is what it looks like when you see that the very short tubing is actually able to flow quite a bit of CSF, despite its small diameter and partly because of its short length. And this, again, prevents CSF from sitting in the device for too long. The other advantage of the e-shunt approach is that you're actually connecting two compartments that are physiologically related. basically the pressure inside the intracranial compartment and the venous pressure that seem to go hand in hand with a set gradient. Compare that to the VP shunt concept where you're connecting the intracranial compartment to a peritoneal cavity which has zero physiological connection. And furthermore, it's hampered by any kind of positional changes of the patient where you can have a siphoning effect, which is dramatic and can result in overdrainage. This has been mitigated recently with the use of anti-siphon device, of course, but remains a challenge. And so you can see you're comparing about a 10-fold to 20-fold difference when you're comparing ventricular atrial or ventricular peritoneal shunt in terms of the hydrostatic pressure gradient. The next challenge became to how do we develop a method of delivering this? Initially the theory behind getting to the cistern or the cerebellopontine angle cistern and the location all are, it's a great objective, but then how do you actually make it happen from a device point of view for delivery? And then how do you make it happen in terms of imaging in the angio suite so you can actually construct a imaging pipeline, interventional pipeline to make it happen? We leveraged the use of imaging and 3D cone beam CT to get a better idea of the anatomy. And again, the concept of this angle change between the horizontal and vertical aspects of the inferior petrosal sinus, effectively this being in the clavis. And so this is the approach that we came up with. Starting with a guide catheter, we advance a 27 thousandths microcatheter, which enables us to deploy an anchor, which is a microstent that has a very thin flat trail. This enables a rapid exchange delivery catheter that has a needle that is preloaded with the e-shunt and that has a guard that is uncovered and then enables the controlled advancement to CP angle cistern, followed by advancement of the e-shunt and then subsequent withdrawal of the anchor, which is a temporary device just to make the navigation through the IPS a little easier. So this is again the two-component delivery system and the needle guard, which is removed when we get into position. So again, the target for delivery is at this site. And if you look at this structure, it's called a jugular tubercle. It's a very important landmark. It turns out that if you look at the half point of the jugular tubercle, and if you go up, that's effectively the target site of access, which is highlighted here. We did testing in cadavers, and we actually leveraged 3D road mapping, which we had available in our angiography suite, but had never really used it for aneurysm work, mostly because I was trained to do, biplane imaging and never really used 3D road mapping. But this was a perfect technique because initially when we were trying to get to that target point, we couldn't figure out how would we do that. Would we use bony landmarks? We came upon the idea of using 3D road mapping. So you can see here, what you do is you select the site of the IPS you want to access, and then you can see after you position in the projection that's orthogonal, you just simply do a negative road map, and then you can actually see the needle exiting the IPS and effectively entering the cistern. Again, because the IPS is in this bony location and you're not dealing with a mobile vein, or like you would, when we're doing a thrombectomy, you can actually see how much deflection you can get from arteries, or even when you're deploying a stent with a stiffer microcatheter. We don't have these issues with the inferior petrosal sinus location. So this is what the approach looks like. You have the needle exiting the dura. This is the cone beam equivalent, showing the flat trail, which we deploy in the cavernous sinus. This is the deployed e-shunt. You can see the malacot, which is collapsible, and I'll show you pictures of that. And then the actual device empties in the jugular bulb. This is the 3D road map showing the cavernous sinus. The anchor will be deployed distally. You can see that oblique kind of Townes view that usually enables you to see the orthogonal wall, upper wall of the IPS, which you're going to be advancing. So this is what the e-shunt malacot looks like in position. And again, this is what the IPS going up in the clavis, and this is the horizontal segment, jugular tubercle halfway point. That's effectively when we exit. You can see again, jugular tubercle halfway point. This is where the exit is on both sides. How do we screen patients? Is everybody able to undergo this procedure? Well, we are luckily have to leverage some of the imaging. This is a procedure that requires a little care in terms of screening. And you basically have to ensure that currently we have a cistern requirement with the current device just for the safety of greater than 5 millimeters orthogonal. Realize that the device enters in an oblique fashion, so we anticipate that the cistern requirement will be much less. And we want to make sure that we don't have any arterial structures here. You can see that the IPS has a large distance from any vascular structures, whereas if you look at the left side, you can see that the vertebral artery here is exactly at the site where you would want to exit. So obviously this will be an exclusion, and this would be a fine site. So we require analysis of T1 gadolinium imaging. However, we hope that in the near future, with the availability of photon counting CT, that a simple CTV or CTA/V, CTA with delayed acquisition, and a photon counting CT will be the single study required, because it will allow us to see the arteries, the veins, and the bony anatomy in one fell swoop. So this is the pipeline of the imaging. After we kind of, how do you perform this procedure in the angio suite? So after you get your microcatheter in the cavernous sinus, sorry about this. After you get your microcatheter in the cavernous sinus, you do an injection and then acquire the cone beam CT. That shows you very nicely the bony anatomy. This is the jugular tubercle here. Halfway up, you select the point where you want to exit. You transfer this to the 3D roadmap. After a few first cases, you can actually do this procedure even without 3D road mapping, just because of the experience that you acquire. But this is the anchor being initially deployed in the cavernous sinus. And then this is the delivery catheter. Here, we're just going to get the orthogonal view, get a negative roadmap, go beyond the access site with the delivery catheter, unsheath the needle, come back, and you see how that straightening, that then sets up the vector for ability to advance across the dura in a controlled fashion. The mallet is now being pulled back and tucked, and then you simply recapture the anchor. This has been sped up, but again, this is another cadaver picture. You can see jugular tubercle halfway point is where you exit, and then you can place it bilaterally in this case. Hopefully you won't need to, and you can also remove it. One of the big questions that we have is what happens when you have an infection or the device is in place and you need to remove it for some reason. Well, you can use a snare to actually pull, and then you can pull out the mallet. Notice how it kind of recollapses, and the dura is self-sealing for the most part, and also the gradient is actually from the CSF to the vein. So we don't anticipate seeing blood in this situation. After having done all this cadaver work, we set out to find a mechanism for moving toward the first patient use in a situation where we would have clinical equipoise, and we felt we may be providing an advantage to the patient. And for that, we partnered with Professor Lilik, who's a great friend. We trained both in California for endovascular in the 90s. He trained at UCLA, I trained at UCSF, and we actually visited the group in his clinic, and chose to work on patients who had developed a subarachnoid hemorrhage, a high-grade subarachnoid hemorrhage, in whom they required continuous drainage because they had become EVD shunt dependent. We felt that by using this patient population, a lot of time they will have had already a ventricular drain on one side. They may be getting a VP shunt on the other side. This is the risk of bifrontal injury potentially. And if we could try to use a E-shunt in this case, and we would have the ability to monitor the intracranial pressure while the EVD is in position. And so this is the first patient that Professor Lilik treated, a 84-year-old woman with a ruptured MCA aneurysm that they coiled in Buenos Aires. And then after a couple weeks, the patient, whenever she had a clamp test, would have a surge in her intracranial pressure as she had become shunt dependent. And so she was a candidate for the e-shunt. We did the anatomical testing, look at the inferior petrosal sinus, showing that it's sufficiently large. This is some of the 3D rendering we do with the magenta showing the IPS. And typically it's a loop of ICA that can be in the way, and we cleared that. And so this is the actual video of the first case. The anchor is distal, and then you can see the delivery catheter is being withdrawn. The needle guard is removed. After the needle guard is removed, the needle is unsheathed. And then as you pull back, you're going to see this transition where the entire delivery system straightens out. And that's kind of when you move from the transition point. And so you're going to see, you see how that needle kind of straightened up. And then there you go. And that basically means that the vector that you're going to apply is going to enable you to advance through the dura into the CP angle cistern. What Dr. Lilik did is they actually did a run through the guider, showing that even with the needle across the dura, there was no contrast leakage into the CP angle cistern. The device was then delivered. You can see the Malacot will open and show this transition as it's now no longer restrained inside the lumen of the delivery needle, and then it can then be released in position. This is what happened overnight. We were really very gratified to see that the intracranial pressure decreased, and in the morning, even with the EVD clamp, her ICP dropped down to 6. And you can see the Malacot in the cistern. This is the ICP tracing, which enable us to reach the primary endpoint, which is the ability to remove the EVD at 36 to 48 hours because the ICP stayed below 20 centimeters of water. We've done 9 additional patients, and they all show that similar trend of ICP decrease. This was very reassuring to us because it told us that it's consistent with the device basically doing what it was intended to do, which is to drain CSF. I just want to show you this case before we transition to normal pressure hydrocephalus. I have quite a significant practice of patients with a transverse sigmoid sinus stenosis and idiopathic intracranial hypertension. Currently, we're treating these with venous stenting in appropriate cases. But if you think about where the device drains, it actually drains at the jugular bulb, where the pressure is usually low if it's not a patient with central venous hypertension, and it makes these patients candidates potentially for this e-shunt approach because of communicating hydrocephalus. These are the patient showing in this compassionate care case the swelling around the optic nerve and the bilateral transverse sigmoid sinus stenosis. This is the IPS, and this is the intraprocedural imaging showing the device being deployed here to Malacot. And at 30-day follow-up, you can see that the swelling decreased. The patient had significant improvement in the headache. And this is a cisternography with gadolinium showing that you can actually trace down the gadolinium into the through the e-shunt and into the jugular bulb on the ipsilateral side, consistent with it being patent. As we had these initial successes, we really centered our effort toward treatment of normal pressure hydrocephalus, which, as you know, affects the elderly. This is an excellent case report in the New England Journal by another group with a regular VP shunt showing how this patient who had been incapacitated beforehand after VP shunt placement is literally a transformed person. And of course, it affects the elderly and has the triad of, gait disturbance, urinary incontinence, and of course, cognitive decline. We felt that this would be a good patient population to treat because they're able to be kind of a more of a scheduled procedure. It is a patient population that's underserved by current VP shunt. Many times patients and their family shy away from having VP shunt surgery because of the risk of surgery in the older population. and we thought we could make a difference. So as part of the testing, gait instability is tested by what's called a timed up and go test, where the patient gets up, walks about 3 meters, turns around, and then sits back in the chair. And that is timed and used to see if the patient improves. So part of the requirement for inclusion in this study is the initial opening pressure is greater than 8 centimeters of water. And after a high volume lumbar puncture or a lumbar drain trial, that they actually have a greater than 20% improvement in their tug test, or they have a better than 20% improvement in their velocity. Urinary incontinence tested by an NBSS score, and cognitive ability is assessed using the Montreal Cognitive Scale, or MoCA. This is the first patient, again, treated by Professor Lilik, showing the E-shunt in position. And again, they performed this cysternography, again, showing the flow of contrast. You can actually trace it down here at 30-day follow-up. And the patient had a significant improvement at 90-day. Their tug test went from over 16 to 9.9 seconds, with also improvement in the Evans index. Since then, we've been able to treat additional patients with MPH. This is at Yale with Professor Matuk, who's been an excellent partner helping us because he has a significant practice of patients with normal pressure hydrocephalus. This is a nice image showing the IPS and the Malachite outside. We've also worked with Professor Siddiqui at Buffalo. They did their first case back in February of last year. And also Professor Rina at NYU with this excellent team of neurointerventional radiologists. And more recently, we did our first case in Kentucky with Professor Frazier. And I just want to show you, this is a patient from Argentina's study, before on the left and at 90-day on the right. And you can see the gait has been significantly improved. So when we actually do statistical analysis on all of the patients that have been treated, there have been 30 of them. So as you know, they've been treated in a staggered fashion, so we're accruing the follow-up. We have had 9 patients that have had this device for an entire year, and you can see the improvement in the timed up and go test is statistically significant, anywhere from 30 to 35%. And that's greater than what's called the MCID, the minimal clinical detectable difference, which is around 16 and a half. So we're continuing to, obviously need small numbers, but we're still continuing to accrue. But so far, the results are very encouraging. So where are we so far with the E-shunt? There have been 41 procedures performed worldwide. And there have been 0 instances of hemorrhage, procedural hemorrhage, as assessed by post-procedural cone beam CT and then post-op day 1 imaging as well. These are the 6 operators that have placed with Professor Lilik leading the charge, followed by Dr. Matuk. There's been 10 for subarachnoid hemorrhage, 30 for normal pressure hydrocephalus, and that one case that I showed you for the IIH. This is the current version of the device. It has an improved delivery system. The stent has been changed to a laser cut, lower profile, kind of a shroud, which enables easier detachment around sharp bends, where the previous stent would have because it was closed cell design, would have the propensity to kink around sharp bends. This is the handle here that you pull out to bring back the needle guard and expose the access. The preparation, which initially in the first version of the device took close to 30-45 minutes, now is done in less than 5 minutes, just by flushing the preloaded device and then testing its function. And this generation of the E-shunt enables the delivery of a microcatheter through the lumen. So in addition to the ability to deploy the e-shunt device, you can actually maneuver a microcatheter, and so it becomes an option to actually potentially travel in the cisternal space. This is just an illustration of this capability. This is the 3D printed cistern in the IPS. And you can see here we have the e-shunt at its exit site, and we're actually able to maneuver a microcatheter both to the contralateral CPA cistern, up into the basilar cistern, and down in front of the brainstem and the cervical spinal cord. One of the dreams that I have is that we'll be able to design a device that will enable us to actually advance, travel intracisternally, and perform a third ventriculostomy from below using fusion and imaging guidance, something effectively akin to this navigation up, and then hopefully advancement into the third ventricle. And so in conclusion, thanks to a work of many and a great team, it's been possible to show that percutaneous access to the central nervous system is safe and reproducible. The e-shunt device seems to have sustained ICP decrease and seems to work in 3 etiologies of communicating hydrocephalus. And it may provide a new platform for delivery of other therapies and possible intracisternal navigation. Thank you very much for the opportunity to present.
Yeah, that was a beautiful presentation, and it was actually really exciting to see the potential applications of your technology beyond just the e-shunt as well. In particular, being able to access the cisterna with microcatheter. So I just have a couple of questions, maybe more directed towards the audience. So first question is, for your clinical trial in the United States, are you focusing primarily on NPH or other diseases?
Yes. So our initial focus was with subarachnoid patients, but setting up a trial for patients with subarachnoid hemorrhage, because of the wide extent of the presentation, the different grades, different location of aneurysm and hemorrhage location, and how they do in the post-procedural, whether they had vasospasm or infarct or delayed ischemia, made it comfortable to perform a randomized study within a reasonable number of patients. The FDA required, looking at the MRS, and then you can see that you would need a very, very large number. And so we focused on normal pressure hydrocephalus. That's our current pivotal trial request from the FDA that we're in the process of applying for and working with to come up with a design. And that's hopefully going to be our first indication, and then when that, if it's approved, then will enable us to go after other conditions with communicating hydrocephalus.
That's wonderful. And then, another question, this is, maybe for, education of the audience. So how long did it take from the time when you came up with this whole concept to when you were finally in humans?
We came up with the first concept, the first discussion, I think, was late 2000s. I think our first patent application was around 2009 or so, and it was actually rejected because the examiner didn't understand the novelty of the concept. So we actually flew down to Washington, D.C., Carl and I, and luckily were able to finally get the patent in around 2013, where we formed the company. So it's taken over 10 years. One of the issue is getting interest. We applied to many kind of funds, innovation and research funds, and were actually denied mostly because they felt the approach was too risky, in a way, too outlandish, right? It was, they didn't think it would work, and so it was really a serendipity that we were able to find an investor who had previously experience with flow diverter and actually came to discuss a flow diverter patent, and then we actually got them interested in this. It's been quite a challenge getting the conventional endovascular companies interested in the project. They keep wanting to get to the point where we have de-risked the entire approach, because it's not, a derivative of, for instance, an aneurysm occlusion device or a stent retriever or a catheter. So we've been lucky; we've been able to get so far. But I would say, it's taking 10 years from initial application to get the first in human, and I would say about 7 years from the inception of the company.
Yeah, it just goes to show. I mean, this is one of the only like truly novel things that I've seen be developed over the course of the past several years. So, congratulations. And are there any questions from the audience?
Yes, Prof. Pescilla, would you like to ask something first?
Yes. Good morning, everyone. Great talk. It was very amazing to see these cases that you have shown. At the very beginning, when I've seen for the first time this technique, I was pretty scared, because it's a completely different. In the terms of endovascular technique. But now I think that this will change our view to treat these patients. I have a question for you. Do you have plan to have the CE mark and to start to also to use this device in Europe? Because I'm very thrilled to use it.
Yes, thank you very much. We're obviously have hopes that we'll be able to bring it to Europe and also the rest of the world, especially in Asia as well, where I think especially for MPH with culture and the respect of the elderly, I think this will be a great procedure to offer in cases. One of the challenges is when you're a small company is to pick exactly what you're trying to do and the small victory before you run out of funding. And so we're focusing right now on trying to get this device through a trial, a formal pivotal trial, and then of course from there, hopefully we hope to move on to other parts of the world and offer it to a larger audience. I think there's a question here which says, what are the complications of the procedure, especially bleeding causing SAH? I think, this procedure for all of us doing neurointervention requires careful planning, pre-procedural imaging. And we've been very careful to not select cases where there's an artery nearby where we think the trajectory may still be okay, but we've kind of been very cautious. We hope to develop a technique where we can go through the dura without having a sharp edge, so that like a trocar when we perform, the peritoneal access. But at this point, with proper planning and screening of the 3D imaging, we luckily have not had any issues of hemorrhage in the 41 cases.
Thank you. Yes, so was this?
If there is any issue about over drainage versus drainage, or
thank you so much for that question. We have not had a single instance of over drainage or subdural. None of these patients have come back complaining of headache or hemorrhage inside the cistern, delayed subarachnoid hemorrhage in the follow-up period. Yeah.
Any different sizes or just one size?
Great question. So far, we have a single size, and it was kind of a shot in the dark, just using just an estimate of what we think we will need. It is possible to make a more permissive valve or less permissive valve, but right now we have a single design.
Thank you very much.
Yeah, one thing that I thought that you brought up was interesting. As a radiologist, was the potential application of photon counting CT for anatomic planning, and potentially even shunt patency. I think that that's really an ingenious potential application because, as you likely know, I mean, the ability to resolve the bones and even the tinier veins and everything with photon counting is going to be really, is exceptional. And likely this will be, the standard CT approach in the next 10 to 15 years worldwide anyways. But I thought that was a very nice application.
Thank you very much. Unfortunately, Waleed, we don't have one at the Tufts. So
we have 5.
Okay.
Well, thank you. Just I would like to ask one question to Prof. Malik before I ask my co-host. The thing about concerns about shunt getting blocked, I understand that it is successful for normal pressure hydrocephalus, but even in the cases of subarachnoid hemorrhage where there is hydrocephalus, even when we put a EVD, there is always a concern and chance that it gets blocked. But in EVD, we have a troubleshooting, like some saline flush may sometimes require. Is there any concern about the shunt getting blocked over the time with
That's an excellent question, and I want to qualify the results that I showed. These were not fresh subarachnoid hemorrhage patients, but rather they had already cleared for a few weeks. So we did testing showing the patency with different levels of hematocrit in the CSF, and it was very encouraging. But these 9 cases that I showed had already cleared their blood out. So we have not done the study where the patient comes in, maybe they get an AVD, and then place this like you would a lumbar drain in a few days, but before a week. To see if you place it, you can kind of wean off the EVD earlier. We have not done that. And of course, if there is a posterior circulation or any hemorrhage where you have clot in the CP angle cistern, it will be, of course, prone to clotting. Yeah.
Thank you very much. Yes, my co-host, Dr. Limunse, any questions?
Thanks, Raja. Thanks, Prof, for a very innovative and a nice talk. I think glad to see that your NPH patient actually improve, even more improvement after 1 year, where current shunt study shows that actually patient improve initially and getting worse subsequently. Do you have any flow study, such as an MRI flow or some radionuclide study to show the patency or functioning of the shunt? And my second question, Professor, you show us a case of a benign intracranial hypertension with venous sinus thrombosis or obstruction, stenosis. Would you think that, would you consider to put a stent and see whether the symptom improve before putting a shunt? Would it be a staged procedure or one procedure? My next question, Professor, is there any contraindication, such as if there's evidence of calcification in the vessel wall, or if the contralateral venous sinus are not well flowed, you may not want to attempt this procedure? And my last question, Professor, would you think that there be a future for so-called presumed obstructive hydrocephalus using this device? Thank you, Professor.
Thank you very much. So I'll take the last question. This device is for communicating hydrocephalus, as you know, and would be contraindicated and obstructive unless we come up with another novel approach. The inferior petrosal sinus approach, you can potentially use it if the other side is occluded. All of these cases were done with intravenous heparinization. So the patient was anticoagulated. Early on, we reversed with protamine, but about 80% of the cases underwent the transdural access while fully heparinized. So I think, of course, like all things, it becomes higher risk if you're going after one site. I would say that the other question I think that you had pertained to contraindication. Of course, central venous hypertension, if you have I guess theoretically the pressure in the ICP should still be higher, but at this point we do not recommend that. And then in terms of the anatomy, in addition to the arterial proximity, we also look, some patients have a bony protuberance over that site. So we also look at the CAT scan to make sure that there is no bony overhang. In fact, some patients, about maybe 5% or less, have their IPS completely in the bone and is actually not seeing the dura. So those are part of the analysis. I would say that it should be possible to treat around, based on purely anatomical features, around 75% of patients all comers.
No, I just for a comment, because I think that this device and MMA embolization are the new frontiers of endovascular neurosurgery and interventional neuroradiology. So I think that in the next years we will treat a lot of these patients. And I'm very happy to be an endovascular neurosurgeon, because endovascular neurosurgery, interventional neuroradiology, the future of endovascular neurosurgery, interventional radiology is bright. So thank you so much to add this technique to our armamentarium.
Thank you very much. Well, thank you very much. It's really been an honor to be given the opportunity to share this with you. Thank you.
Well, thank you very much, Professor Adil Malik and Professor Walid, for this exciting and wonderful session, and congratulations for this wonderful innovation. We are all looking forward to future applications of the device in other forms of hydrocephalus as well. Before we move on to the second session, I would like to inform our viewers that this is being broadcasted on the YouTube, WeChat and Zoom channel, and as of now we have around 1,275 people who have logged in from all around the world. Thanks to Professor Shubin for doing this for the ACNS. So I'll invite Professor Simon Pestillo to say a short introduction and invite our honorable speaker Wasim Aziz for his lecture. Dr. Pestillo, all yours.
I think that this topic it's very important, because have to allow us to better understand what kind of treatment we can tailor to the patients. So I would ask to Professor Aziz to share his screen.
Thank you, Simon.
I think that it's very important to have an hybrid perspective, because with this hybrid perspective you cannot have any bias of treatment, and I believe that Professor Aziz will go more deeply in this. So please.
So thank you, Rajan. Thank you, Simon. It is a pleasure and honor to be with you today and discuss this topic. This is my city, Abu Dhabi, and this is the desert of Abu Dhabi. Abu Dhabi is a very beautiful city, and we can see very nice atmosphere, but not in the summer. Summer is very hot, but in the winter it is the best winter you can be. And I'm very thankful for this talk today. I have been to Japan several times, and my brother and friend, Dr. Mushiro Tanaka, I visited him last September, and we spent a very good time together. And I have been to Tokyo, Japan K University in 2005, a long time ago. And this is my daughter wearing full kimono. And so brain arteriovenous malformations are relatively uncommon, highly complex vascular lesions that can cause significant long-term morbidity and mortality in young patients, mostly due to intracranial hemorrhage. The incidence is estimated to be 1 in 100,000. Population prevalence is up to 0.14. There is annual risk of rupture, which is well known. And according to the size of AVM, we know that does the AVM size matter? Small AVMs are considered to carry higher risk for cerebral bleeding than larger ones. And the location also, the location matters. This may be true for AVMs with increased risk in some locations like basal ganglia and thalamus. So the treatment for AVM, the modality, it's multimodality, surgery, treatment, or changed our way of managing AVMs, especially unruptured ones. And now we rely more treatment for the ruptured ones. So our strategy first is cure by embolization. This is our intent usually, or cure by embolization and surgery. If not possible, cure by embolization and radiosurgery or target treatment. So this is the case of female, 21 years old, presented by this hematoma in the head of caudate, in the caudate nucleus. And when we do the angio and the CT angio, we find this AVM, which is located in the corpus callosum. It's exactly depicting the corpus callosum and splenium of the corpus callosum. You can see in the AV view and lateral view here. In the posterior circulation injection, in the vertebral injection, you can see the AVM taking supply from the posterior choroidal arteries too. And here when we go endovascularly to treat, we usually go with a microcatheter deep inside the nidus. And this is the nidus picture I like to see before starting injection of any onyx. I be sure that I'm deeply inside the nidus and no backflow in major arteries or more near to the vein, so I can include it early. So this is how the onyx diffuse and occlude the nidus of the AVM. And this is before and after. And we can see this is the first session, and this is before and after. Also, this is after the second session. And we can see here the onyx cast is depicting the nidus exactly inside the corpus callosum and inside the splenium of the corpus callosum. And this is after first session. This is after second session of embolization. We can see this is after the first session from the anterior circulation. This is from the posterior circulation. We can see the nidus is completely occluded. This is another case of a difficult AVM in the posterior circulation. And we can see here the nidus. When the microcatheter lodges deeply inside the nidus, we can start our injection. And this is before and after. In the AV view, this is before and after in the lateral view. This is the MRI post-operative. We can see the patient had a good outcome. And this is what I like to see in the onyx cast. This is the onyx cast. I like to see it this way. No reflux into major arteries, back reflux, which is loading and may lead to complications. This is another patient. We did embolization followed by surgery. This is a female patient, 28 years old, presented by this posterior Sylvian AVM, led to intracerebral hematoma. And this is the AVM on the lateral view. This is after attempting embolization. We couldn't achieve much because of the embassage arteries, and I was not able to get full control of the AVM by endovascular route, so I decided to go for surgery. And this is the intraoperative view. You can see the superficial part of the nidus is embolized with onyx. And we gradually dissect the nidus. The arteries we cut. It's easy to cut thrombosed or embolized artery by onyx with a scissor. And then if there is usually we find smaller feeders still viable. This is the AVM. And usually we get the part which is not embolized in the depths. And this carries a difficulty during surgery, because superficially you will find the part which is embolized. In the depths, we will find the part which is not embolized. This is the draining vein. We can see the draining vein. We try to leave it until the end. So we go deeper and deeper. We load, and then with time we go more deep, and we go around the nidus of the AVM, and at the end we can remove it. So this is a post-operative MRI. You can see the nidus is excised. This is another case of old case done maybe 12 years ago. And this is the patient presented by intraventricular hemorrhage and brain hematoma. We find this nidus AVM and with the hematoma, the frontal lobe. This is the AB view and lateral view. We can see it's very small nidus, but still linked to bleeding. This is the microcatheter through the anterior cerebral artery. We can see very small corrugated vessels, which the microcatheter will never reach the nidus this way. This is the lateral view. So I could reach this position, which is a good position to inject. I injected hystoacrylin in this situation. And this is the cast I injected. So this AVM is not completely treated. So I need to go for surgery to completely excise it. This is the vein of the AVM. So we follow the vein. The AVM is not visible on the surface, but I need to follow the vein until I see the nidus. So this is the draining vein. I try to follow it until I see, you see the foot of the vein here. So now I can identify the nidus. I coagulate the feeders gradually, and I try to leave the vein without occlusion until the end. Otherwise, there will be maybe bleeding or angry brain if I try to load the vein early. So gradually I excise the feeders little by little, then cut, disconnect the nidus from the surrounding circulation and the surrounding brain. I don't use retractors usually. I use my sucker to retract the AVM, not to the brain, not to retract the brain. I retract mostly the nidus. And then at the end, I put clip on the vein and then cut the vein and excite the AVM. So this is the post-operative angio. AB view and lateral view, you can see that the nidus is completely removed during surgery. And this is the post-operative CT. The patient did very well. This is another patient with embolization followed by surgery. This is a male patient, 40 years old, presented by this hematoma in the frontal lobe. This hematoma in front of the motor cortex. And this is a CT angio. This is also an old case, maybe 10 years ago. And this is the AVM and the MRI. And we can see here the AB view and lateral view of the injection of the conventional angio. You can see the injection of the conventional angio. I had to embolize, and when I embolize, I could take this superficial part of the AVM, but the deep part supplied by the lenticular striate still very difficult to reach with some intranidal aneurysms. So this is the lateral view. This superficial part of the AVM is completely occluded, but the deep part still there. The vein is still flowing. So this is the onyx cast. This is what I want every time after injection. And then after surgery, we can see that I removed the nidus from the lateral view. We can see there is no nidus anymore. This is an old case, so the video is a little bit not very high quality, but we can see the onyx. I gradually work on the nidus. It's easy to work on a nidus which is embolized by onyx. You can just cut, there will be no bleeding. And I go deeper, and then I started to find the unembolized part of the nidus now. So this intranidal aneurysm is embolized. But when I go to the depths, which is the more difficult part of surgery, because in the depths there is no control, the control is less. So this part is not embolized. You can see that the vessel is still viable, and this is the part supplied by the lenticular striate from the depth. So we cut the unembolized part. We use coagulation, bipolar coagulation, and then cut. This is part of the embolization, the onyx. We don't use diathermy here near the nidus because it's the problem. So we started to surround the nidus, cut from all corners, from all sides, 360 degrees. We surround the nidus and we go to the depths. This is the most difficult part in the depths. So this is also in the deep part. And once I'm sure that it's coagulated, I cut. So this, I started to manipulate the nidus. This is the very callosal artery, and I disconnect the nidus, leaving the pericallosal intact. Otherwise, the patient will have complication. So I coagulating the cut from the keeping the pericallosal patent. And then at the end, this is also still part of the nidus, which is still viable, still living. And then at the end, we excise, take it totally. This is the vein, part of the vein, and then everything went fine. The patient went okay. This is the angio. This is the X-ray before and after, and we can see the patient did very well. Another patient, which is embolization followed by surgery, this is an occipital hematoma in a young 20-year-old male patient with this small AVM. First, I tried to embolize it completely. This is the nidus in the AV view and lateral view. And here we can see the microcaster reaching the nidus. This is a very good position to inject. I injected this. This part is completely occluded. Then when I came here with the nidus, I found this very tight bend for the microcaster to reach and to cross this bend. It's very difficult, and this is superficial AVM. It's the risk and grade 1 Spitzer Martin, so it's very easy to surgically. So I decided to take the smaller part remaining by surgery. This is the AVM before and after the lateral view of injection, and this is the patient after surgery, no complications. This is another case of AVM in a young boy, 7 years old, deep in the thalamus, and this is the AVM. You can see the AVM supplied by the branch from the thalamoperforators. This is the branch in the CT angio. You can see it. And this is the AVM lodged inside the posterior part of the thalamus. And we can see here the AVM in the AV view, lateral view. So this is magnified view. So I tried to use detachable microcaster here. And then I found this also bent, and I thought it's not a good microcaster to treat. So I take it out and I used the non-detachable one, and I could navigate it till the nidus, deeply inside the nidus. This is the AV view, this is the lateral view. You can see the nidus and the veins flowing out of the nidus on this location. And this is before and this is after embolization by histoacryl. This part is treated. This is the AVM. This is before and after. Still, there is a small remaining part. So I refer this patient for radiosurgery. This is the histoacryl cast inside, lodged inside the thalamus posterior part. This is before and after embolization. And then this patient went to radiosurgery and completely cured for the smaller part. This is another patient, embolization followed by radiosurgery. This is another AVM ruptured many times with intraventricular hemorrhage. Patient stayed in ICUs, back improves, then go out of ICUs, then rebleed again. And here the young patient, male patient, is teacher. So he has this nasty AVM inside the corpus callosum. We can see it in the AV view and lateral view. It's inside the genu and body of corpus callosum. This is a microcaster reaching the, not embedded in the nidus, but here this is embedded in the nidus. In this position, I can't do anything. In this position, I can embolize. And this is a vein. And this is veins, aneurysm. This also microcaster here. And this microcaster inside the intranidal aneurysm. In this position, we can embolize. And this is before and after embolization. This is before and after. And we see here the cast of material, onyx and histoacryl. I used both in this case inside the body and genu of corpus callosum. This is a cast. This is a cast. The smaller part remaining also sent for radiosurgery and done. And with radiosurgery, it is obliterated. This is another AVM in a 37-year-old male patient. We see the AVM here located in the midbrain with intraventricular hemorrhage. This is the AVM inside the midbrain, inside the colliculus, superior colliculi of the midbrain. And then we can see in the MRI. This is the shear circulation injection, lateral view, AV view. And we can see there is intranidal aneurysms here. This is a nasty AVM bled. And this is the 3D angio picture. And this is a microcaster inside the aneurysm, the ruptured aneurysm inside the AVM. This position is very, very good for embolization, for injection of onyx. So I started to flow onyx inside the nidus. This is the aneurysm. This is after more onyx injection. This is after embolization. I could get good part of the AVM with intranidal aneurysm. This is the cast of onyx inside the nidus. And this is the MRI post-operative. We can see here there is a smaller part in the posterior part of the AVM, superior part of the AVM. So this is also the MRI before and after. This is before and after we took a good part of the AVM. And then this patient also sent for radiosurgery and he is doing well. This is a case which is staging is very important. This is a very old case also, maybe 10 years, more than 10 years. And before Aruba trials, this is a non-ruptured case in a young girl. This is the AVM. You can see the AVM is a Sylvian AVM. So this is the AB view and lateral view of the AVM. You can see it's completely inside the Sylvian fissure in the left side. So I started to embolize it with onyx. And then I took this part in 2 sessions, this part also in the 3rd session. So we can see here the nidus. And I took this part in 1 session, the posterior part, then the middle part, then the anterior part in 3 sessions. There's still remaining parts which sent for radiosurgery. So this is the lateral view before and after. This is the onyx cast. Patient did also well, no, just very minute hemiparesis after the 3rd session, but patient tolerated it very well and improved after a few days. This is the onyx cast. This is another patient, which is a female patient. She has multiple bleedings in her, inside the brain and in intraventricular. She suffered a lot, many times of bleeding. And we can see this is a very nasty AVM. We cannot cure it, but I thought I can try to decrease the size. This is also an old patient, maybe more than 10 years ago. And we can see the nidus. We can see here the draining vein. This patient has memory problems. She cannot remember her family. She cannot remember her sons and daughters, her husband. So I decided to take a good part of it. This is a posterior circulation part. This is the posterior part in AB view and lateral view. And this is the intranidal injection. And this is after 10 minutes of onyx injection. This is after 20 minutes. And I could take all this posterior part, all this part. You can see the flow in the draining veins slow down. And also patients after she started to have more memory and she became better, but I lost her for follow-up after that. This is another patient also with hydrocephalus. You can see a huge nidus in the posterior fossa. This is also more than 10 years. I will not do these cases anymore after a Aruba trial. So this is the nidus. I thought I can take part of it. So this is the injection. This is the nidus with the posterior part. So I took this part. Also, take this. This is after taking some parts. This is the posterior part. I left the brainstem part. So this is the amount of onyx. And you can see here in the MRI, this part is still lots of AVM. This part is completely occluded. I was away from the brainstem part, not to risk the patient's life. Patient luckily survived without complications. And this is the number of cases we did long time ago. And this, my conclusion, the procedure-related transient neurologic deficits was observed in 1 case, the 18-year-old female having left Sylvian large AVM, which improved. There was a complication in the cells, complication in the cells. After radiosurgery, he started having memory deficits, memory problem after the radiosurgery. and intraoperative rupture noted in 2 procedures, and with continued embolization, patient did very well. So safe and effective management of brain AVM should be performed in the context of well-designed, rational treatment plan. This plan should consider endovascular embolization, microsurgery, radiosurgery on an individual approach that is fundamentally based on clear understanding of the natural history of the lesion as well as the cumulative risks of treatment. So thank you. I'll be happy to meet you there. Thank you.
Thank you, Wasim. Great talk. You have clearly demonstrated how it's important to have an hybrid approach in brain AVMs, and in particular in complex cases like you have shown. Which is your rate endovascular treatment versus open surgery for brain AVMs?
Usually I go for endovascular. This is the first.
And this rate changed over the years? Sorry, and this rate changed toward the years or not?
I usually try to occlude endovascular, but I have low tolerance to push to the limits for endovascular, especially if the AVM in a superficial location, which I know that I can excise it. So I don't try to push to the limit until I have complication. So if I feel that this part still there, but I can remove it surgically, I will go for surgery. And also I don't push the limits for surgery. So I try not to push the limits for every approach. For endovascular, I don't push my limits because I know AVMs are dangerous and complication is very high. And for surgery, also I don't push for the limits for surgery. So I usually try to combine both. And if I found any difficulties, I don't push the limits for both embolization and surgery, and send the patient for radiosurgery because there is a small remaining part, especially in large AVMs, especially in deep located AVMs. Because I think the limits is the reason for complication. If you try to 100% cure it by endovascular, you will get complications. If you try 100% to remove it surgically without endovascular embolization, you will get complications. So combination is the best.
And once you plan to treat an AVM endovascular first and then surgery, how long it takes from one treatment to the others, or you do surgery just after the embolization?
If I plan staging for endovascular, like I will plan staging, usually I stage it in like maybe 3 weeks, 1 month between every stage of endovascular, like the cases which has endovascular staging. But if I will plan surgery, I will take the patient immediately to surgery after embolization, after like the male patient with occipital AVM grade 1. After I know that he will not be completely embolized, I took him to surgery directly. So it's according to the plan. If I plan staging for endovascular, I will wait some time. If I plan surgery after, so I will take him to surgery directly.
Okay, thank you. Great cases. Do we have any question?
Yes, we can invite comments from Prof. Malik as well. Prof. Malik.
Yes, great, wonderful cases. What is your microcatheter of choice for those very distal access that you were able to achieve? What do we like to use nowadays?
There is microcasters because this case is mostly like 10 years ago, so I used to use the non-detachable tapes, the Sonic, and also I used to use detachable tape casters from Covidien. So it's according to the case and according to the material I will use.
Great, wonderful. And what do you use a gamma knife or a saber knife, or what is your choice for the radiosurgical treatment?
We don't have UAE gamma knife, so usually those patients are sent to Korea because here in UAE they send gamma knife to Korea, and I'm not sure they use gamma knife for second. We don't have gamma knife.
Thank you very much, Prof. Aziz. Just one question: in patients who present with intracerebral hematomas, I understand is surgery of evacuation and hematoma with AVM excision is your first choice, or you would just evacuate the hematoma, do an endovascular, come back at a later stage? What is your principles in these types of
Usually I plan evacuating the hematoma and removing the AVM at the same time. I have several cases and didn't include in my presentation, but usually if there is a hematoma midline shift emergency, I go evacuate the hematoma and tackle the AVM.
Right. Thank you.
But if the AVM, yeah, I don't. No.
Understood. Well, thank you very much. I think we can conclude as there are no further questions. So right, I will do this officially now on behalf of the Education Committee of the ACNS and the President, Prof. Yuko. I would like to thank both speakers of today, Professor Adil Malik and Prof. Wasim Aziz, as well as the chairs, Prof. Walid Bunchiki and Prof. Simone Pestillo, for this time and support for the ACNS webinars. It's very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel, and also special thanks to my co-host Dr. Liu Bun Sen for joining me today. So until we all meet online tomorrow, it is bye bye from all of us. Thank you very much for joining.